Hi, this is Llewellyn Kell. I'm the Quality Assurance Director here at Prestige, and this is part of your orientation. Um, I'm going to cover the basics of home care, the homebound status, skilled need, and some parts of Medicare versus Mass Health and Medicaid in general. The basics for skilled need are homebound status, skilled need, and an order from a physician, podiatrist, or doctor of osteopathy. No PAs and no NPs are allowed to sign the initial plan of care. The difference between Medicare and Medicaid and some other private insurances are that the homebound status can be eliminated if there is substantial need for skilled services. So we will go over both the homebound status for Medicare and what we'd like to see in general, because we'd like to follow the Medicare guidelines as much as possible, as sometimes the skilled need for a patient will increase and we will need to bill Medicare. So we want to be able to ensure that we're always compliant. Part of the team is the patient. The main part of the team is the patient and what their goals are. The physician steers their plan of care due to the orders. There's nurses, home health aides, social workers, physical, occupational, and speech therapy, and we now have a medical social worker. Home health care is provided under the conditions of participation, which is a set of guidelines that are set up by Congress and Medicare. Each skilled professional needs to document the skill with which they are using for the services that are provided. So physical therapists would require a different set of skilled needs than, say, a nurse. If the care does not meet the criteria for skilled need, theoretically we can provide the service, but that the patient would be required to pay for it. OT is the only secondary service that can continue after the primary services, RN, PT, or speech therapy, have discontinued visits. So OT can stay in and be the one to discharge, but they can't, so they don't need an RN, a PT, or a speech therapist to continue to see them. The MSW may not continue if the RN or the therapist is no longer seeing the patient, but they can offer phone consultations. Once the patient is no longer homebound, under Medicare, the services need to stop and they need to go to an outpatient setting. If they're a Medicaid patient and they were skilled under Medicare, and now they're more of a chronic patient or have different needs, but they're no longer homebound, we can convert them to Medicaid and they become a different reimbursement source. But we do continue to have to bill Medicare first in order that they can continue to see them under Medicaid. They're both required. The homebound status. This is probably the hardest part of what we do in paperwork-wise, is justifying that a patient is homebound or not. A patient can go to an MD office, they can go to church, they can go to the barber or hairdresser, they can theoretically drive, but if they're driving, then we should be looking at whether they need to be discharged. The goal is for a patient to be able to receive services in the most cost-effective manner. So the most cost-effective would be them to go to an outpatient clinic to receive the services rather than a one-on-one in their home. So if they're able to get to an outpatient setting, that would be the goal for them ultimately. The other part of it is our skilled need and our teaching that could theoretically be done in a clinic or an MD office. So if they're able to get in and out of the home without a taxing effort, then that's where they should be receiving those skills. However, many of our patients, whether it's from psychiatric, emotional status, cognitive status, physical status, require a taxing need to leave their home. lack of transportation does not fulfill the homebound qualification. It is not always a permanent status. You can be recovering from surgery, you can have an accident, you can be acutely ill for a period of time and be homebound due to that diagnosis. But you can't change it from day to day. So if somebody has major depressive disorder and they're depressed for 3 weeks and are homebound during that period of time, we couldn't just say each day that it changed. It has to be over a period of time. However, the vast majority of our patients are Medicaid patients, so we're not looking to bill Medicare for their homebound status. It still has to be accurate. One of the things about homebound status is that if you identify what their diagnoses are, especially their major contributing diagnoses, so COPD, CHF, osteoarthritis, whatever's causing their main problem usually has to do with their homebound status. So if they have cancer and they're having chemotherapy, or they have kidney failure and they're getting dialysis, sometimes that diagnosis gives you a clue as to why they are homebound. It doesn't have to be every day that they have the debilitating fatigue of dialysis, but if they're having it those 3 days that they go in and they have dialysis, then that justifies why they may need a second home health aide visit for the day. They may need another additional evening visit if they get confused, if they're exhausted. What you're doing is you're painting a picture of what home care services for this patient looks like. And they don't have to be cookie cutters and very similar to one another. They shouldn't be. So one of the things that they can do is they can go to dialysis, they can go to chemo, they can go to radiation. They really shouldn't be driving themselves. The taxing effort part is what you need to focus most on. So the patient can go out, whether or not that causes them to require a nap for 2 hours after they get back. If they're so short of breath that they need to sleep on an increased number of pillows that night. If they're less active the following day, if they have poor sleep, if they miss their medications, those are all things that substantiate why you're needing to go there, because their going out is really taxing for them. Another part of it is assistance. If they require assistance to get up out of bed, they require assistance to eat, they require assistance to bathe, to get up and down the stairs, they can't manipulate their walker by themselves, they require somebody to physically be present, even if it's not directly touching them, but to supervise them and make sure they safely can get in and out of their home, in and out of their beds, in and out of their car, their bus, their special transportation, the ambulance. If they require somebody to assist with that, then they become what we consider homebound. They can take occasional and infrequent outings, that's very specific, to a hair salon, a church. They can go to weddings. It really isn't about whether or not they can get out of the house. It's about how much need they have and how hard it is for them to do it. And ultimately, it's really about, would they be able to make it to a clinic? Would they be able to make it to a rehab without it becoming so difficult for them that they actually decline and they regress? A lot of the homebound status documentation has to do with diagnosis related, and there's some very specific diagnoses, whether it's a CHF and somebody has dyspnea and they have a low tolerance for activity, a COPD or requiring an additional oxygen or one of their PRN medications to go out. But also, if you add in, there's a whole component of them having psychiatric and cognitive difficulties. if a patient is physically able to leave their home, but emotionally they cannot, then they become homebound due to their inability to emotionally leave. Psychiatric conditions can often, especially if they're non-compliant, can often be demonstrated as homebound, even if there's no physical reason for them not to be able to go out. Some of the things that you would normally see in somebody who you would want to be consistent. That's actually the key part of this, is when we submit a prior authorization to an insurance, we want all of the supporting documentation to be the same. Different ways of even explaining the same thing is very important. So if a home health aide is documenting that a patient needs a shower bench and needs a walker, that they're having an increased difficulty in, climbing stairs, and that they need that extra 15 minutes in order to get them in and out of the house. Just say you were going to a group adult foster care. That's still considered homebound because the patient, that's not considered a self-driven activity. That's when somebody is being transported. It's like daycare, theoretically. You wouldn't expect somebody to be able to get themselves to an appointment if they're somebody who can't take care of themselves in their home during the day by themselves. So bed-bound, mechanical lifts, if they require a wheelchair, a reclining chair, a commode, they require an assistance for transfers, that they're chair-bound, they can't ambulate for more than 20 feet without shortness of breath and rest periods, they have morbid obesity, and they have severe pain in their hips and their lower back, and they can't carry their belongings to go out, and they're short of breath when they get to the bottom of the stairs, or they're dizzy when they get to the top of the stairs, and they need somebody to make sure that they're steady and that they have their assistive device. That becomes somebody who needs assistance. Significant weakness and fatigue, progressive diagnoses like an MS, an ALS, terminal illnesses of any kind, you're anticipating a continued decline. The next section is skilled need. The skilled need is an intermittent care. It doesn't mean it's long term. The plan is for if there's a change in a cognitive or psychiatric condition or a physical condition, that prompts a education relating to that diagnosis or that event. With each problem you identify, there should be a very comprehensive evaluation of where the patient is at, what their goals are, and how we're going to go about meeting that goal. The skilled need to do with wound care, diabetic care, IV infusions, sub-Q, IM injections, prescribed exercises, are initially taught to the patient or caregiver. And at that point, if the patient is able to learn or the caregiver is able to learn, then our role as professional nurse or therapists become to reassess and supervise whether or not they're able to do that skill. Once it moves on to supervising and skilled assessment for whether it's being done correctly, there are specific parts of it. So accuracy, compliance, necessary updates or changes, side effects, infections, complications. They don't justify the need for long-term services. However, if there's any non-compliance or if they have any increased difficulty, then the needs change. So the physical therapist, occupational therapist, and social worker, skilled nursing may need to be increased as they're not able to provide that level of care and that level of expertise. Sometimes you need to be sometimes you have to dig for it in the referral documentation to know exactly which problems the doctor wants you to address. Any doctor that is communicated with at any visit should really have a communication note included with what the physician said, what we communicated to them, and any changes. That change justifies the services. The OASIS documents are done by PT, OT, I believe speech, and RNs only within the team. So the RN involved needs to be updated by the home health aides and the LPNs and any other person involved in the care of the patient. It's the responsibility for the home health aide to identify who the RN case manager is and go to that person with what issues they're having. The RN oversees and supervises the team. However, they're responsible for that patient and making sure the plan of care has been updated. Plans of care should be updated, and changes should be made with any new issue or with any change in status. Patients have the right to fail, and that failure justifies their need. You need to document that. A patient's ability to learn can be affected by their psychiatric or cognitive status, at which point they're failing to be able to understand something makes it possible for you to continue to care for them. Basically, the clearest part I can say is that if you're thinking about it in terms of a discipline, so skilled nursing, PT, OT, home health aide, any of them, identifies a problem. Within that problem, there's a time frame. So when did it start? When did it become a crisis issue or a problem? And what has been done since then? The related diagnoses, testing and labs that support it, progression of severity. So then you get to the point where you look at it. So say you're doing skilled nursing, cough, 3 days would have a different plan than if they have 3 months with streaky red bleeding in their sputum. But they build on one another. So once you've proven that the 3 days wasn't an upper respiratory infection, when you get to 3 weeks, you check them out and send them to the pulmonologist. If it's not something easy to figure out, they'll send them to another specialist. There will be labs, there will be x-rays, and we need to find out what those things are. Once you get through your part of it, you need to know what part the physician is involved in, what interventions that they have put into place, what interventions do they want you to put into place, what the goals are of the patient. So a patient doesn't necessarily have the same goals you do. Their goals may be to just be able to go out to lunch every day. Your goal may be for them to learn how to do their diabetic medication and make sure they take their afternoon pills at the right time. So depending on what level of they are at cognitively or psychiatrically may affect what their goals are. Within every document that we review, we want to see what has happened in the last 60 days, what's happened in the last 14 days, and what is going to happen in the next 14 days. Within every recertification, 60-day summary, even every daily note, we want to see one specific problem that you're identifying, what specific thing you're doing to move them to the next stage of independence, because that's ideally what you're doing, is you're trying to figure out a specific plan to promote the optimal level of independence. And if that patient isn't able to be independent, then they do become a chronic care patient. Doesn't mean that they cannot continue to learn specific things to do with their diagnosis, and we should be trying to teach them specific plans because they should be able to participate as much as they possibly can. If they're getting to the frustrated, anxiety-provoking period of education, you may want to consider whether or not what you're teaching them may be too complex for their level. Sometimes very small windows. So you're teaching somebody diabetes management, and you go in and you don't try to teach them the whole thing all at once. Try to get them to draw up the insulin. If they can draw up the insulin to the correct amount, then you know that they can do that part. If they can't, and they can't even see the line, then you know that that's going to stop right there. They're not going to be able to fill their own syringes. You need to be able to document that that patient pulled up the insulin to 10 units as opposed to 8 or even 4, and what the effect that would have that had on them, or that potentially could have happened based on what they're using. the skills have to be very personalized, very specific to that patient. And they want to see what the patient's response is to those. With each thing you're teaching them, the effect it has on their plan of care is how you're going to justify the need for services. Each separate diagnosis should also have very specific skilled need notes relating to that. They don't all have to be on the same day, but if somebody's having difficulty with their diabetes management, the next week should really be focused on a different problem to give them a chance in order to catch up and perhaps absorb more of the information. A lot of what we're doing at this point is making sure that what we're documenting is really what we're doing. We do a tremendous amount as nurses and all care professionals to allow them to be the most optimum independent level that they can. And we're afraid almost to document the bad things, that they have, their clothes shades and they haven't eaten in 3 days, and, that they have foul smelling, bathroom. They need you to say those things on their behalf. They need you to explain to all of the insurance companies why their specific need is so severe, and they're not going to know unless we explain it to them. It isn't doing them a disservice to share those sorts of things with the staff, with other members of the staff. If you're a home health aide and you're noticing that there's something wrong with this patient, your information is just as valuable as any other discipline. And sometimes it's actually more so, because you're seeing them on a daily basis, you're taking care of them, and that might trigger a continued need for services, which justifies why you're in there. We really want to make sure that patients are appropriate at the right time for the right reason, and that will ultimately make it so that we'll all succeed, and the patients will succeed, because they know that there's no rush to get them off of service, but there's also progress being made. We need measurable progress or measurable decline, and that also will justify their services at this point. So thank you so much for listening. I hope you have a wonderful day.